Good afternoon, everyone. My name is Dan McHale. I'm the Senior Vice President of Healthcare Finance and Policy here at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, Following the Money, What Federal Medicaid Changes Mean for Massachusetts Hospitals. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature. We are in a listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2025 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of the many events we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I am pleased to introduce our speakers from the law firm of Hooper, Lundy, and Bookman, Lloyd Bookman and Paul Garcia. Lloyd is one of the founding partners at Hooper, Lundy, and Bookman and is one of the nation's most accomplished healthcare attorneys, trusted by hospitals, providers, systems for reimbursement, investigations, and compliance counsel throughout our country. Paul is a partner at the firm and represents hospital associations, health systems, clinical laboratories, and in complex reimbursement disputes, audits, and regulatory matters across Medicaid and Medicare. MHA's own experience with both Lloyd and Paul trace back to our association's work to develop significant changes to our state's hospital Medicaid assessment program in 2022. When it was time to craft that plan into legislation, we turned to Lloyd and Paul. Nothing is simple about the Massachusetts Hospital Assessment Plan. It's probably one of the more complex approaches out there. To add to that, it's built on a very confusing part of the general laws in our state related to the Health Safety Net Trust Fund. For a couple of lawyers from California, Lloyd and Paul followed it all impressively and provided MHA with expert advice to ensure the trust funds, tax language, and funding transfer that house and move this funding was done in a way that represented Massachusetts hospitals in a fair way. MHA most recently leaned on these gentlemen as we considered further changes to the hospital tax in light of recent congressional action that became the One Big Beautiful Bill Act. Without a doubt, Lloyd and Paul are legal experts in healthcare, especially related to government programs, and we are pleased to have them join us today. So with that, I'll hand it to Lloyd and Paul to get us started.
Hello. Thanks for the introduction, Dan, and we are pleased to be here. I'm gonna start us off with some introductions. And when we think about the One Big Beautiful Bill Act, or HR1, which we'll call it during this presentation, we're talking about a sweeping federal tax and spending package, which is almost 900 pages long in statute. And it delivers, significant tax cuts, which are offset by huge reductions in healthcare spending. There's, I believe, 34 specific statutes under HR1, which relate to healthcare. But most consequential when we're talking about policy and dollars are the cuts that are to Medicaid, and then followed by ACA exchange provisions as well. From a fiscal perspective, this bill is projected to reduce Medicaid spending by something like $8 trillion over 10 years, with an additional approximately $21 billion coming from exchange cuts in exchange subsidies. There are going to be additional changes related to Medicare. There's also a rural health program, which maybe we can get to at the end. But sort of the center of gravity and what we're going to be focusing mostly on is Medicaid, the Medicaid program, and the implications that it has on providers, including, providers specifically in Massachusetts. As I've mentioned, the bill is massive. The dollars are massive. It's really hard, even for someone like me who's in this constantly, to sort of wrap your head around the magnitude of everything. So we can't cover everything, but what we can do is try to give you an overview of some key topics. Those key topics are going to be, first, coverage losses and eligibility impacts. That's going to be what I like to call sort of the people impact. I think a lot of times we think about the cut in the dollars to providers. But a whole host of new federal requirements that we're going to get into, like work mandates, redetermination requirements, changes to premium tax credits, they're going to reduce the number of enrollees who are in the Medicaid or the exchange programs. Next, we're going to talk about Medicaid reimbursement cuts. And because that gets particularly wonky, I'm going to hand that section off to Lloyd Bookman when we get there, because it gets really complicated. There's going to be structural changes to the Medicaid financing and reimbursement mechanisms, including new limitations on provider taxes and on state-directed payments. And then finally, we're going to open it up and try to be as conversation as possible, in talking about Massachusetts-specific financial pressures and other pressure points. So without further ado, I'm going to get us started on our first topic, which focuses on coverage losses and eligibility restrictions. And again, before we jump into the slide, I want to highlight that first and foremost, there's going to be an impact on people. And this was not hidden. When you look at the CBO scoring, for example, a huge majority of the cost savings are directly because there's a projection to be a decrease in the number of enrollees. And so the bill introduces, things like mandatory work requirements and eligibility restrictions and other administrative hurdles that are designed to reduce the number of individuals which are covered by Medicaid and the exchange plans, and in turn reduce the federal spend. These changes are expected to increase churn, reduce access, again, reduce the number of enrollees. And the upshot is, from a provider's perspective, is this is going to shift some financial responsibility to providers. I mean, just because people don't have healthcare coverage doesn't mean people stop getting sick. So let's dive in first and foremost to the Medicaid work requirements. And these are going to be effective in January 1, 2027. They're going to apply to non-disabled, non-elderly adults without dependents. And those individuals are going to be required to either work or go enter into job training or certain educational or community programs for at least 80 hours a month. So the CBO estimates approximately 9 million Medicaid enrollees are going to lose coverage over 10 years because of these work requirements. And we've seen this play out in real life. Both Georgia and Arkansas put in place Medicaid work requirements. And there was a detailed Harvard study, particularly on the Arkansas program and what the upshot was. And if I'm recalling correctly, at risk of oversimplifying it, I think the Harvard study sort of showed us that there's two things. Work requirements, A, do not lead to more people getting jobs, but they, B, do lead to more people getting disenrolled. And that's why we see the number one sort of factor in the reduction in spending and in the reduction of enrollees are going to be those Medicaid work requirements. But that's not the only thing that's going to impact enrollment. The next is there's eligibility redetermination requirements. These actually impact, I know it says ACA there, there's actually going to be more onerous eligibility requirements on the Medicaid side and the ACA side. So HR 1 does have, as I mentioned, some impacts on the exchanges. And obviously it also has impacts on the Medicaid program. Under the statute focusing on Medicaid first, there's going to be a new requirement to require semi-annual redeterminations. There's also reductions in retroactive coverage, so people are going to have to prove that they're eligible to the Medicaid program more frequently. And then if they lost coverage and become eligible again, the coverage period is going to be reduced to 1 month for most adults. I think it's 2 months for certain categories of beneficiaries. So again, this is something that we expect to increase churn and increase the administrative burden. There's a similar provision in HR 1 related to the exchanges. Again, the idea and then the practical impact is there's more red tape for enrollees and beneficiaries, the more work that they have to do, the upshot, at least the expected upshot, is fewer people getting coverage. Then another, oops, sorry. Uh, Give me 1 second. I didn't mean to change that. Here we go. I want to speak a little bit more specifically on the exchanges as well. So I just mentioned um, some of the additional red tape for the exchange related to the exchanges when it comes to enrollment. There's also going to be, and I don't want to focus too much for this presentation. We want to focus mostly on Medicaid, but there's also going to be limits in the exchanges related to premium tax credits and eligibility for premium tax credits for non-citizens, LPRs like asylum seekers and refugees. There's an elimination of income-based special enrollment periods. There's going to be a removal of a premium tax credit recapture, which is basically if if it turns out at the end of the year that somebody got more premium tax credits than they were supposed to get, predicated on their income, there was a cap on how much money they had to pay back. Now that cap is being removed. And then there's another lever, which is not HR1 specific, but it's very important. And maybe we all understand if we've been looking at the news. We have the looming expiration of the enhanced premium tax credits. So the enhanced premium tax credits originally expanded on the American Rescue Plan. And they're set to expire at the end of 2025. And this is in part one of the reasons we see the government shutdown and fighting between the respective parties. The subsidies currently cap premiums at around 8.5% of income, and they provide like zero premium or very low premium plans for low income individuals. If Congress does not renew the enhanced premium tax credits, based upon there's a whole bunch of different numbers out there, but it looks like premiums could double easily for millions of Americans in 2016. I saw one estimate from Kaiser Family Foundation that there would be 114% increase on average. And I think the dollars were over $1,000 a month for exchange eligibility if the enhanced premium tax credits are not renewed. So while not OBA specific, it is also really important and timely to understand. We have all these different sort of we have these work requirements, we have more red tape, and we have a loss of premium tax credits, all of which are going to have a direct impact on reducing the number of enrollees and making things harder. All right. So now I want to go through what this means in Massachusetts. And first and foremost, a lot of the figures that I'm pulling are from a publicly available bulletin that was issued by the Massachusetts Taxpayer Foundation, or MTF. That is, I guess that what I want to say is that if you dig around, there's going to be a lot of numbers. You're going to see a lot of numbers from a lot of organizations, and these are all going to be estimates. But these are the best estimates we could find for the purposes of trying to relay what this all means to the audience for Massachusetts. So as you'll see here, the upshot of those different levers that I discussed is going to be 300,000 total enrollees expected to lose coverage. It says due to HR1. I just want to caveat that we talked about not only HR1, but we also talked about the expiration of the enhanced premium tax credit. So I believe that's factored into the 300,000 figure. That was something like on the Medicaid side, my understanding is it's something like 10% of all Medicaid enrollees are expected to lose enrollment of current enrollees. And that is something that we've seen similar, if not higher, figures or estimates in other states. We also have the additional 270,000 individuals who are expected to see meaningful reductions in their premium tax credits, with the upshot being skyrocketing premiums. And again, just to be specific, that's not specifically related to HR1, but it is going to be real. And that is factored into the estimated 300,000, in total enrollees. But we don't know how it's going to play out, because there's going to be people who aren't considered super low income, but they're going to face serious financial pressure to continue paying for healthcare coverage that they've been getting under the exchanges. Then the last bit is just sort of to think about, just take a second and think about practically what this is going to mean. So what we expect, and I've given several presentations on this, heard several other people speak about this. What we expect to see are things like increase uncompensated. So first, let me frame it. As I mentioned, and it's important to keep in mind, just because people don't have health insurance doesn't mean people stop getting sick. People are going to keep getting sick. And that burden in part is going to fall upon providers. So we expect to see things like a higher emergency department utilization at hospitals. Patients without coverage are likely to delay care until conditions get to a point where they have to show up to the emergency room or maybe the urgent care room. We expect that there's going to be an increased burden on uncompensated care, right? So people are going to show up, for example, in the emergency room. Hospital can't turn those people down, right? And you're going to need to provide that care, and there's going to be this huge or growing uncompensated care bucket. This is also the reduction in individuals is going to cause strain in Massachusetts to the health safety net trust fund. And the health safety net is already under pressure with funding shortfalls. Based upon the figures that we have available, my understanding is that shortfalls were prior to legislation, which is in the queue right now, being voted on the legislature, was something like $284 million was the shortfall. We have potentially $77 million in supplemental relief in front of the legislature right now. That's stuff that Lloyd and I worked with MHA closely on. But the bottom line is, even with the additional funding, we're expecting a significant shortfall for the health safety net. And the MTF, Massachusetts Taxpayer Foundation, threw out a number. They said that the budget shortfall could grow to over $510 million annually due to future coverage losses and other pressure points. So the upshot is going to be huge financial strain, particularly on hospitals. And one final point, again, focusing on people, is I'm seeing this a lot in California in particular, is our clients are reporting to us that people have growing reluctance to get enrolled in particular immigrant populations, minority populations. So for example, lawfully present individuals who have concerns from things like ICE raids and stuff like that. And they say, no, no, I don't want to apply to the Medicaid program because of heightened fears of immigration enforcement and because some of the stories going out there of people, regardless of whether they're here legally or not, people being afraid that they're going to get in trouble, people being afraid that they're going to get deported, people being afraid of public charge implications. So against this backdrop, there's even more sort of pressure that could result in fewer people enrolled. With that, I'm going to turn it over to Lloyd, and Lloyd's going to talk about the reimbursement and financing provisions under HR 1.
Thanks, Paul. Nice to be here with all of you. I will say, in response to some of Dan's initial comments, that your hospital assessment and supplemental payment programs and your legislation in Massachusetts is among the most complex and complicated that I've ever seen. The good news for purposes of this presentation is that we will not be getting into all of those details, the various funds and the various relationships between the funds, but rather a more general discussion of how HR 1 is going to affect in an overall sense, the hospital assessment program you have, as well as the state-directed payments. Most states, 49, have a provider tax. And why do states have provider taxes? States have provider taxes, and these started to become most prevalent probably in the 2000s because states' budget constraints, because of budget constraints, states declined to increase base Medicaid rates. You had that in Massachusetts, we had that in California. It's happened all over the country. In order to kind of backfill the state reluctance to adjust or increase provider rates, hospitals and others around the country turned to taxing themselves. And taxing themselves in order to generate the non-federal share. As you all know, Medicaid is a joint federal and state program. The state has to put up a state or non-federal share. That non-federal share is matched by the feds, depending upon a particular percentage in the state. For example, in a state with a 50% match, the feds put up $1 for every dollar the state puts up. But the federal law also allows local and other taxes to be used as the non-federal share. So what many states have done, including like 49, is to tax providers, particularly hospitals, take the tax money and use that as the non-federal share of of Medicaid payments in order to draw down federal funding. So for example, if you're in a 50-50 state with a 50% federal matching assistance percentage, and you were to generate $1 billion in taxes from hospitals, that $1 billion goes up to the state, and the state then uses that $1 billion to draw down $1 billion in federal funding to turn $1 billion into $2 billion, and that $2 billion now goes back to the hospitals. So the hospitals, in effect, earn a $1 billion profit on their taxes in the aggregate. One of the interesting downsides of provider taxes and the increased prevalence of the provider taxes is it's allowed the states off the hook. And as a result, the states, in many states around the country, the states have just been reluctant to increase base rates and have relied more and more heavily on provider taxes. Congress recognized that provider taxes could be, if you will, a loophole in requiring the states to actually put up their own money in order to generate federal funding for Medicaid, and has enacted a number of restrictions on how provider taxes work. One of those restrictions is that a provider tax currently cannot exceed 6% of net patient revenue for the class of providers that are being taxed. What HR 1 does over time is it takes that 6% down to 3.5% by federal fiscal 2032, reducing it 0.5% each fiscal year, beginning federal fiscal 2026 or 2027. For Massachusetts, the upshot is two things. One, your level of net patient revenue that can be attributed to your provider tax will not be able to be higher than it is currently. Currently, it's in the low fours, roughly about 4.3%. So you will never be able, under HR 1, to increase the percentage of net revenue for your provider tax beyond that 4.3%. That's one implication, and that continues going forward. The other implication for you is that this doesn't actually probably impact Massachusetts' hospital assessment until federal fiscal 2031. That's October 1, 2030, because that's by October 1, 2030, the maximum percentage of net revenue that a provider tax can be would be down to 4%, and you're higher than that 4%. And then by federal fiscal 2032, it goes down to 3.5, so you're going to have to take another haircut in your hospital assessment. So this isn't going to have an impact on you today, right now, but it'll have an impact in the out years. A lot of what Paul and I are talking about today, particularly in the provider tax and the state-directed payments, has an impact in the out years, after the midterms. There's also a uniformity requirement. We don't have to worry about that for Massachusetts, we don't think. Some states tax heavy Medicaid providers higher than other providers, or tax, say, Medicaid days at a higher rate than other days in order to reduce the number of providers that pay more in taxes than they get back in supplemental payments. CMS doesn't like that, adopted a uniformity rule that was then baked into HR 1, but we don't think that's a problem for the hospital assessment. So I won't talk about that any further. We think you're okay under the uniformity provision. But we do think you're going to be facing reductions and restrictions in the hospital assessment, but probably not until October of 2030. Okay, Paul, advance to the next one, please. Let me talk a little bit about state-directed payments. And by the way, on the on hospital assessment, you have about a $1.5 billion hospital assessment. So it's a pretty big program. But again, you're going to be okay, we think, until October 1 of 2030, at which point without a change in the law, you could be facing some reductions. State-directed payments. What are state-directed payments? Generally, under the federal Medicaid program, the states cannot tell the Medicaid health plans how they're going to pay providers. They can't direct health plans to pay providers in a particular way. Well, that rule was ignored largely by states until about 2016, when CMS issued new federal Medicaid managed care regulations saying, no, we really mean it. States cannot tell providers, or excuse me, cannot tell Medicaid health plans how they're going to pay providers, cannot have minimum, cannot have rate restrictions, cannot direct what those payments are, because that's really not managed care. Managed care means that the health plans are going to be receiving a capitated payment, the health plan is going to be at risk, and the health plan is going to be obligated to provide services, contract with providers, and that's going to all be on the health plan. Except the 2016 federal Medicaid regs allowed certain types of state-directed payments if certain requirements were met. So most states have state-directed payments running through their managed care programs in significant amounts, which supplement the contracted base rates. In Massachusetts, you have a significant set of state-directed payment programs. According to your state Medicaid agency, it's a total of about $2 billion annually in state-directed payments from the managed care plans. Much of that goes to hospitals. So you're looking at significant, what we call state-directed payments, running through your managed care plans to the hospitals. You're okay. The HR 1 probably doesn't impact you until about till October 1, January 1 of 2028. So you're probably under HR 1, as it's been drafted and enacted, unless there's a change in the law, you probably don't feel an impact on your state-directed payment until October 1, 2028. Oops, Paul, go back. Thank you. Starting in 2028, HR 1 phases down state-directed payments by 10% annually for Massachusetts until you hit, until you're capped at Medicare rates. The idea is they want to move the state-directed payments down to Medicare rates over time. Currently, state-directed payments can go as high as the commercial contract rates, the average commercial contract rates, or the ACR, which is substantially in excess of most states' Medicaid rates and substantially in excess of Medicare rates. So over time, under HR 1, the idea is to move or limit the state-directed payments to what would have been paid under Medicare rates. For you, because you have an existing state-directed payments for Massachusetts, this will start impacting in the 2028 rate year. That is around January 1, 2028, it'll start hitting you. And so the state-directed payments beginning January 1, 2028 will be reduced by 10% annually until you get down to Medicare rates. We don't know the delta right now between Medicare rates and what your state-directed payments are. We don't know how much the managed care payments to hospitals, including state-directed payments, are in excess of Medicare rates, but we got to believe there's going to be a considerable delta there. And so over time, you're going to start losing 10%. And if there's about doing the math, if there's about $2 billion in state-directed payments today, and if you lose 10% of that beginning January 1, 2028, that's a $200 million hit. And that'll continue to continue to be reduced at the 10% rate until you're down to Medicare rates.
Lloyd, I just wanted to chime in really quickly. In September, CMS issued a letter, which is sort of a letter saying, "Hey, we're going to start issuing guidance on the state-directed payment rates and the particular HR1 statute related there too." The way that the statute is written is it says it's going to change the regulation, and as Lloyd discussed, we're going to be going from a cap at commercial rates to the Medicare rates. Well, what that means is super TBD. Like the devil is going to be in the details because when we think about Medicare versus Medicaid program, first, Medicaid covers people that Medicare doesn't. There's not a lot of pregnant women and children who have Medicare coverage. Two is Medicare has bundled rates, in particular for inpatient and outpatient hospital services. But the way that the statute in HR1 is written is it looks like it's at a service level. So there's questions on how we translate bundled payments into what looks like a service level cap. We don't have that information. So trying to figure out what the delta is going to be is like really hard until we know what CMS is or how CMS is proposing to actually track this. And it's going to be super complicated, I assume, and they'll be looking for public comments, and it'll be a long process to figure out those details.
Absolutely, and I'm assuming the details under the current administration will not be helpful to the provider community, particularly in certain states. So I'm not anticipating a lot of help in determining from the federal government in our determining what the help in a positive way in determining what the Medicare cap is going to be. So I think that is all we have on state-directed payments and the hospital assessment provider taxes. And now we'll sort of talk about some of the implications of all of this on Massachusetts. As you can see from this slide, and as you all know, your hospitals are struggling. 6% of the hospitals reported negative operating margins, median of -2% in federal fiscal 24. 74% of the hospital systems operating in a deficit in that year with, again, a median margin of a -2.7%. So things are hard. And obviously HR1 is not going to help. Much of the provider tax and state-directed payment impact isn't going to hit you right away. That's not going to hit you until sometime beginning in 2028. But the eligibility restrictions are going to hit earlier. And those are going to start impacting. Now, states have, and I don't recall if you covered this, Paul, but states have the ability to request an extension of time to implement some of the eligibility requirements, but those will still be hitting within the next couple of years. And so you're going to start feeling that impact very shortly. And it's going to be, as Paul said, we're going to be losing lots of enrollees, and it's going to be you're going to see a lot of more unsponsored, uncovered patients coming through your emergency departments and are going to be losing Medicaid coverage. One of the things we're telling our hospitals to do, and we suggest you all consider, and you're probably doing already, is to enhance or soup up your hospital admissions processes or to help patients sign up for Medicaid to help them with work their way through the eligibility process. It's going to be more and more difficult with the re-enrollments and and providing whatever documentation is ultimately going to be required to demonstrate that they're meeting the work requirements. That's going to get continually more and more difficult, and patients are going to give up. And so, we would, suggest that you think about how you can assist your patients who are coming into the hospitals with that whole process. Also note, as Paul said, what we're seeing in California, and I expect you're seeing in Massachusetts, a reluctance on patients to provide the financial information necessary to enroll. They show up in the ED, they know they're going to get service, and given the current immigration environment nationally, they're reluctant to provide any information, even if they're here legally and even if everything is perfectly okay. Folks are just reluctant to provide any information because they know they're going to get service anyway. So we're seeing that as a strain right now, and seeing hospitals trying to deal with that and figuring out how to convince patients that it's safe to provide information to be enrolled and eligible in your Medicaid programs. One of the other, I think, challenges that you're all going to be facing is how do you project anything? What are your financial pro formas going to look like? If you're going to go out to the bond market, how are you going to do a pro forma? How are you going to estimate cuts? How are you going to estimate the impacts? I think it's a very challenging environment to do that. One of the places we're seeing this all play out is in facility purchases and sales, including purchases and sales out of bankruptcy proceedings like the Steward bankruptcy, where we've seen buyers back away because they say, wait a minute, we have no idea what the financial performance of this organization is going to be like over the next 5 or 10 years. It's just too difficult to predict. We're backing away. And that's, of course, going to depress prices on healthcare facilities. So, I think it's a particular challenge to try to project your financial performance going forward. And then,
Lloyd,
go ahead, Paul.
I just wanted to run something past you that I frequently hear. I gave a presentation recently, and folks said something to the effect of, when you talk to hospitals, CFOs, they'll say, oh, we lose a ton of money on Medicaid. Maybe we break even or lose less money on Medicare, but we make all our money back on commercial patients.
Yeah.
And I know Massachusetts and California happen to have share some similar provisions related to just in healthcare generally, both expansion states, similar, tax assessments, et cetera. But importantly, there's also the healthcare cost benchmark program in Massachusetts, which I don't think you and I are necessarily experts in, but my understanding is it's not so easy for a hospital to say, oh, we're going to take a huge hit on the Medicaid side. We're just going to juice up our commercial rates. And I'm curious, am I seeing that right? That it's not so simple, and maybe it makes projecting even harder.
Yeah, and I'm not an expert on the Massachusetts program. I am more expert on what we're doing in California, having copied Massachusetts and souped it up to the point where the Hospital Association filed a lawsuit against our cost targets, which are modeled after the Massachusetts plan. We filed a lawsuit a couple of weeks ago to challenge those targets, in large part because we're concerned that the Medicaid cuts that are going to be hitting California, reducing substantially Medicaid reimbursement, and we won't be in a position to be able to shift those unreimbursed costs to private plans. In fact, the plans are coming back to us in California and saying, I'm sorry, we can't even give you a normal inflationary increase because of the cost targets in your state. And so not only we're not going to get a normal increase, we're not going to be able to shift new unreimbursed Medicaid costs to the private plans, which is the lifeblood of many hospitals. We're going to take a haircut. Now, my understanding of your targets, if you will, is that it's a less onerous process. The plans are free to negotiate whatever rates they wish to negotiate with you and whatever the market will generate, although there is a benchmark that they're required to at least attempt to achieve. And the plans may throw that benchmark back in your face in negotiations and say, hey, wait a minute, we'd love to give you more money, but I'm sorry, we've got the benchmark that we've got to try to achieve. So I think it makes it, it's sort of a double whammy. You're getting into an environment where Medicaid rates and Medicaid payments, Medicaid eligibility is going to be constrained on the one hand. On the other hand, you have no place to go to shift those unreimbursed costs. So I think it's going to be more and more difficult. Now, it may be that the state agency that runs your your program dealing with the establishment of the benchmarks might show some flexibility in that regard and take that into account and increase the benchmarks. That may be a place to go with your agency that runs that program. We've tried that in California, and it's fallen on deaf ears so far.
I want to click to our second to last slide. But more importantly, I think I just want to open it up, Lloyd. You and I have given several presentations to countless people on this, and it's not exactly a rosy picture. And I think audiences often leave and say, so like, what's going to happen? What do we do? What's next? Um, and I think we should just sort of share some observations and some thoughts. One thing is that I just wanted to note is truly the devil is going to be in the details. So when we talk about things like benchmarking the state-directed payments to the Medicare rates, there's going to be complexities. We're waiting for technical guidance on how the redetermination process is going to look, what exact paperwork is going to be needed, how often is it going to be processed. There's issues with different state Medicaid programs have different technologies, so there's huge IT issues, um, et cetera. Everything we're talking about, lots of devil is going to be in the details.
Great.
Then we have sort of, if the picture is hospitals are already in a dire financial strait and this is just going to make it worse, then what happens? I had the occasion of speaking on this topic to a group of restructuring folks, distressed assets folks. So they're interested in things like the entry of private equity into hospital space, the potential increase in Chapter 11. What happens when we go through Chapter 11? One of the things that was mentioned is that hospitals, part of what makes things so difficult on hospitals is they have a huge, it's like going to the Cheesecake Factory and they got to check off every single item. They got to provide every single item on the menu. And for some hospitals, it's just not viable to do so. So do we have to sort of change what some of the requirements are from a licensing perspective and the services? We're going to see more ambulatory service centers. So anyways, Lloyd, I just wanted to open up on some of your thoughts on what are we looking at in the future?
Yeah, I think a couple things. I think that there's going to be the consistent tension between regulators who want to impose requirements on hospitals that sound good. It sounds like, yeah, we should ensure that hospitals provide the service and have the staffing ratio and do this and that. But those sound good, but there's not going to be money that's going to follow that has followed and is going to continue to follow those regulatory requirements. So my thought is until we actually see hospital closures or on the brink of closure, and we're in crisis mode, we're not going to see responses from state legislatures, state regulatory agencies that reduce the burdens on hospitals and help reduce their costs. I'm thinking. My thought is this is going to be one of those unfortunate circumstances that until we see some real challenges, some real difficulties, we're not going to see a breakthrough. Now, there are points in HR 1 where states can show some more flexibility. I mentioned that states can seek an extension to some of the eligibility changes. One of the requirements is that in the new bill is that states impose a copay requirement on Medicaid beneficiaries, but there's no minimum copay requirement, no minimum amount, so the states can take advantage of that and make it very minimal. So states have some flexibility, but boy, I see with the pressures on state budgets nationally, I'm not sure where we go for the money, and I'm not sure we're going to see a lot of regulatory relief. My impression for most state agencies is they think somehow or another they can regulate, tell you what to do, and the money side is somebody else's problem.
Speaking of the money side, when HR 1 was still sort of in the political, zeitgeist trying to get passed in the House and in the Senate, one of the things we heard a lot was, hey, but we're going to be pumping money back into the this rural hospital program, which is a $50 billion program. And just want some quick math when you look at $50 billion vis-a-vis a $1 trillion budget cut. The numbers don't line up, right? Two is states are already submitting proposals for how to get this $50 billion. And it's sort of going to be a mad scramble. And my impression, Lloyd, is it looks like maybe non-rural hospitals have access to something like half of that $50 billion, but we don't know how it's actually going to play out. And
Right.
it's going to be a lot of people who are in desperate financial situations who are really trying to fight and scramble over a piece of that money.
I don't disagree. And the portion, it's a drop in the bucket, and the portion that is actually going to go to rural hospitals is discretionary based on applications being submitted. And you know you're going to see applications for well more than the amount of the available funding. I'm concerned that the political environment nationally will influence which state gets what money, which would mean that the blue states wouldn't fare nearly as well as the red states, and that's a concern. So I think the $50 billion rural hospital pot of money was a sop to folks nationally to try to publicly lessen the impact of HR1. I don't think it's going to save a lot of rural hospitals. I think the rurals are unfortunately in big trouble unless states act to help them out.
Right. Another thing I think it's important. Oh, really quickly, I see we have a question um from Nancy Kaysen. I just don't know the answer to this question. It's about pre-ACA Massachusetts healthcare. I think that was so pre-2010. I was I think an undergrad at that
I can
time.
help out.
So was it so Dan, do you have any
Yeah, sure.
background on this?
Having lived it. Yeah, so in terms of Massachusetts healthcare reform, going back to, former Governor Romney in 2006, where Nancy points out we were successful in reducing the number of uninsured, and that certainly continued throughout the ACA implementation. But our health safety net fund had minimal funding shortfalls with the ramping up of coverage. I guess what's changed in the nearly 20 years, we have the same amount of money, upfront money going into the trust fund as we did 20 years ago. And so even if we had uninsured back in the day, and we have them today. I mean, not everyone can be covered by Medicaid, as well as the subsidized insurance in the exchange. We're always going to have a certain level of uninsured despite our best efforts. When you have the same amount of money from 20 years ago, you just naturally have higher costs provided by hospitals, community health centers, pharmacy, a big gross spending. And so that is, one of the main reasons why we have a growing shortfall. And there was some trimming done in the program's eligibility kind of midway there through that also helped to relieve some pressure. But we're now certainly in a much different state, and the forecast is dire.
And Dan, it makes me think one thing, which maybe I didn't properly couch for the audience. In the ACA environment, we had essentially a carrot for states to expand the number of Medicaid patients, for example, increased premium tax credits for beneficiaries, get more people enrolled in exchanges, increase FMAP, so federal matching dollars in the Medicaid side. Under HR1, we sort of see the opposite. There's a number of provisions in there which are indeed designed to reduce the amount of money or to penalize expansion states like Massachusetts and like California. So not only are the specifics different regarding what happened under Governor Romney's tenure, but sort of the legislature's intent now is we want less money going to federal money going to expansion states. We want fewer enrollees. We want basically them to cover more of that burden via their state budgets moving forward.
Yeah, that's exactly right.
And I don't know if there's any other points. Dan, is there anything that we missed that you think is particularly important to the audience? And if the audience has any particular questions.
One of your predictions, I guess, Lloyd, that you had at the end was concerning, where we're not going to have perhaps action until we see the damage. And that's super concerning. You know, perhaps policymakers have seen us, you know, survive a pandemic. And certainly we had extreme financial circumstances then, and we've managed to get through it. But we're still living, the results of those in terms, and then we compound that with inflation. The
Right.
cost of doing business is higher, the workforce strains. And now we're going to layer on coverage losses on top of a already fragile safety net. I think, this presentation is focused on Medicaid cuts, but you appropriately intertwine that with just the affordability kind of expectations of commercial insurers and employers. We have folks looking at 340B, which is
Right.
essential revenue source to safety net hospitals, discharge hospitals, critical access, so forth. That's under threat. So, waiting until the damage is done. I mean, we've already had some experience in this state of actually losing 3. We almost lost another 6. Related to the steward. Certainly, we have always have continued pressure on hospitals. So we're hopeful that we can see this forecast and enact. And I think we're hopeful, especially related to our waiver. And I'm wondering if others are seeing waivers as opportunities, even despite this administration. As it's the first probably Republican administration we're going to have to work with since George Bush. I mean, but other states, do you see the waiver as an opportunity there?
No, I'm sorry, Paul. I'm sorry, Dan. I see the way. I mean, you do have a waiver coming up in 2027. You've got to do a new waiver, and you will. And I hope it's not worse than the current waiver. I think you'll do fine to not make have things get worse. I think you're dealing with an administration that's not going to want to spend any more money, that doesn't believe people who are not otherwise eligible for Medicaid should get health care. Seems. I mean, it seems to be where things are at. So I'm not optimistic that the current administration, since you're going to be doing the waiver under the current administration, is going to show a lot of flexibility. I'd like to be more optimistic for you, but I wouldn't bank on it. You might want to hope for an election change that'll result in a new administration and do a new waiver after in 2029. But I'm not going to bank on having a basically a real additional cash infusion through a new waiver.
There's
It's
also
more
budget
challenging.
neutrality requirements under the waivers, and some of the tricks that state Medicaid programs used to play, they don't pass anymore.
Yeah,
I live
yeah.
that in the state of California. So I hope, but it's hard to imagine the waivers are going to make things better. Maybe they can stay baseline or sort of prevent catastrophe, but it's hard to imagine that this administration, and particularly under HR 1, is going to allow waivers to be the vehicle that makes everything right.
Yeah. And the other thing that concerns me, Dan, and we're seeing it in California, is that at the same time we're losing all this federal money, we're losing eligibility, we're having hospitals with negative margins that are on the brink. We have state budget constraints that are remarkable, and we're out in our state. They're trying to reduce some of the state spending, including state spending on healthcare. We covered folks under a state-only Medicaid program that we're not going to cover anymore. So it's going because of state budgetary concerns, and I know you have those concerns in Massachusetts as well. It's going in the opposite direction. So I don't know that the state's there to backstop things. And what we're really afraid of is a snowballing effect. People who are not in a Medicaid program, who have private insurance or employed, think, oh, that's Medicaid. I don't have to worry about it. Well, no, that's not. If you lose your hospital, you lose your hospital. And you lose your hospital for everybody. If EDs have to close because hospitals can't afford to keep the ED doors open, because if they do, they're going to get a lot of unsponsored patients, well, that's going to close the ED for everybody. And if the ED gets closed in one hospital, there's a snowballing effect, of course, on the rest of the hospitals in that community. So, I mean, I hate to be presenting a dire picture, but I think it is a short-term, few-year dire picture until things are bad enough that folks start to say, "Oh, this is really bad. It's affecting my constituents. I really need to do something about this." Anyway, that's what I'm seeing, and I hate to be the bearer of doom and gloom, but that's what we're seeing. I think ultimately there'll be an upside. But it's going to take a while to get there, and there'll be some pain.
Yeah, I mean, I think that's fair words of caution for everyone. But know that MHA here, we certainly will be doing our best to shape that waiver, shape state finances in a way that can support hospitals. Want to thank both Lloyd and Paul for joining us today. Excellent presentation. Certainly a lot of details behind all this. And please shoot us an email, and certainly can reach out to both Lloyd and Paul for further information.
Absolutely. Well, hopefully next time we present, we'll have a rosier picture, a rosier outcome.
Yep.
But it's tough right now. It's just the reality.
Right. So thank you all for joining today. Please scan the QR code there for future MHA education events. Once again, thank Lloyd Bookman, Paul Garcia from Hooper Lundy and Bookman for joining us today. Thank you all.
Thank you.
Take care.